Hello, welcome everyone to the MD Anderson Cancer Center Integrative Diagnostic Medicine Case Conference for June the 5th, 2020. It's a pleasure to be here with you today. And I subtitled this series, Adventures in Neuro-Oncologic Diagnostic Medicine. And whether this is lunch and learn for you on the West Coast or happy hour on the East Coast or bedtime stories in Europe, what better way to start your weekend than the Integrative Diagnostic Medicine Case Conference. The patient, 19-year-old female. I'm going to do something different in this conference. Most of the time, I like to present a lot of cases, a lot of images. Each one has a pithy little lesson. We're going to do something different today. We're only going to discuss one patient. I know that many of you, probably everyone listening to me, has participated in case conferences, given case conferences. What would you say is the average number of slides that you would present per case in a case conference? Well, I have about 170 slides for this particular case. And I thought instead of covering a bunch of topics with one small lesson, we would take one case, fairly complicated, in detail and talk a little bit about the diagnostic process and the diagnostic problems that are encountered. Okay, so let's begin. I've already given you two huge pieces of information, two of the 8 Venn diagram data spheres, differential diagnosis spheres, in that the patient is 19 years old. That's right at the cusp of pediatric and young adult, adolescent, probably falling into, in most surveys, pediatric series go up to 20 or 21. So really in the pediatric / adolescent age demographic and female. And we'll see how all that plays out as we discuss the case. All right, history. The patient presented with a 2-week history of severe headache without any associated neurological symptoms or deficits. Patient was treated with analgesics and sent home. Fairly rapidly, the patient over the course of the next few days developed gait imbalance, came back in, and at that point, MR imaging was ordered. So here comes our next 2 pieces of data. We have age and gender. Here comes anatomic location and imaging characteristics. Data spheres 3 and 4. All right, we can look at these 3 coronal, T1 with contrast. I'll give you a second to sort of take that in. Coronal sections, clearly you can see posterior fossa mass, but the panel on the far right shows something interesting going on in the middle fossa. Let's move to axial sections, T1 with contrast. Again, a large cystic, multicystic, and solid, avidly contrast enhancing mass in the posterior fossa, centered at these particular cuts in the cerebellopontine angle, right cerebellopontine angle. And the one key, there's a key feature that I hope you're seeing in the middle panel. Take a look at the middle panel. What is the key feature? For a cerebellopontine angle mass, what is your differential diagnosis? Vestibular schwannoma is the first 10 things on your list. What are you seeing right here in this panel? That is the 8th nerve on the right here where the mass is. And you can see essentially more or less a straight line going across the IAC, right, internal acoustic canal. Now, there is no involvement of the acoustic canal. So the right 8th nerve and IAC are not involved, so it's not vestibular schwannoma. It should not be. Now, there are instances, there are rare instances of CPA only vestibular schwannoma, or let us say schwannoma, may not be vestibular, may arise from 7th nerve, etc. Obviously, the Obersteiner-Redlich zone would have to be far proximal in order for that to happen, but there are cases. However, that's at the bottom of your differential diagnosis. So now we have to start looking at the other entities on your differential diagnosis list below vestibular schwannoma. All right, let's turn our attention to the other really interesting feature. Not only is there posterior fossa involvement, but this is key. It tends not to catch your eye. If you're just doing a superficial, quick and dirty examination of these images, what you're going to see is big enhancing CPA mass And if you're sloppy, you're just going to say, ah, it's probably a schwannoma and move on without looking at the eighth nerve, without doing due diligence, without paying attention to details. Details are critical to our business, and our business for diagnostic radiologists and surgical pathologists is diagnosis. Our business is details, not sloppiness. All right, so what's going on here? You can see the mesial middle temporal lobe. That is Meckel's cave. It is expanded greatly, and it's involved by both the cystic component and the solid. You can see kind of the lumpy components of the mass. All right, that is a huge piece of data. This is kind of a game changer. All right, look at the T2 sequences. Again, I think very dramatically shows the cystic components and also the involvement of right Meckel's cave. Really highlights it. So this tumor is paralleling the course of the fifth nerve. If you think about it, from the pons, cerebellopontine angle, up through Meckel's cave, the right cavernous sinus was also involved, and the eighth nerve is not involved. So what would rise to the top of your differential diagnosis in this setting? Give you a second to think about it. That's enough. Trigeminal schwannoma. Absolutely. Second most common schwannoma after vestibular schwannoma. We see them with regularity in the tertiary care referral centers. So trigeminal schwannoma goes to the top of the differential diagnosis. What do you think happened next? Now I'm saying, let me back up because I'm actually misspeaking. What I meant to say is trigeminal schwannoma goes to the top of the imaging differential diagnosis, not necessarily to the top of the overall differential diagnosis using the Venn diagram data sphere model. It's actually not. It's not at the top of the diagnosis. Why? It is at the top based only exclusively on the imaging features, but that is where radiologists get into trouble, and that is where pathologists get into trouble when we confine ourselves, when we limit ourselves to one data sphere and just barely dabble in the other data spheres. That is very dangerous. If you put trigeminal schwannoma at the top of your list, does that mesh with the presenting signs and symptoms? I'm sorry, does anyone even remember? Was anyone even paying attention to the signs and symptoms? It was headache, followed by incoordination, gait instability. Are those the common features at presentation of trigeminal schwannoma? No. What's the number one symptom? Pain, facial pain, trigeminal neuralgia. All right, this patient had none of that. In fact, had no localizing signs. If you ignore that when you're looking at the imaging, that's going to be a problem. That's going to trip you up. So this case it has instantly become very interesting. Now, let me say this. Any one of the 8 Venn diagram data spheres for this patient, any one could be atypical, at one end or the other of the Gaussian distribution, the normal distribution of all features, or whatever it is. But it's troubling, and when you have it, and it raises the bar, is what it does. When you have an outlier, the bar goes up, all right? So in terms of differential diagnosis. Okay, guess what happened next? What happened next was surgery, and we're gonna have tissue. So let's see, maybe it is a trigeminal schwannoma, certainly fits with the imaging data, and it's just an atypical clinical presentation. Maybe the facial pain will be coming. Okay, everyone ready for the H&E? All right, here's where the pathologists, kick in. Here's the H&E. All right, this is low power. It's interesting, it's a lot of pink, isn't it? A lot of pink, and then some areas not so pink. Let's go to higher power. Oh, this is interesting. At this power, the pink stuff, what are the possibilities? Obviously, collagen is going to be number one. You might think, how about amyloid? Is there such a thing as isolated amyloidoma of Meckel's cave? Yeah, absolutely. Cavernous sinus, yes, absolutely. But this is much bigger, much more significant. It really doesn't fit with that. Probably going to be collagen. Let's go a little bit higher. All right, now we're getting a very good look at it. It is, in fact, collagen. It's dense, fibrous collagen. And in between are these small cells, don't even hardly catch your eye. And in this particular area I'm showing you, they have very little to no discernible cytoplasm. That's because the cytoplasm is cleared. All right, it's clear. It's essentially fried egg cell tumor, like oligodendroglioma and others. So these are clear cells, very inconspicuous, and essentially by volume outnumbered by the collagen. All right, so what do we know about the H&E histology? All right, histology, histologic features, histologic characteristics are another Venn diagram data spheres. Dense, blocky collagen, and very prominent and small inconspicuous cells, round to oval nuclei, cleared cytoplasm. And we want to put that together with the imaging. This is how we are building, all right, our differential. How does that change your diagnosis? Does anyone right off the bat, who's not familiar with the case, of course, know the answer? Anyone right off the bat know the answer? I'll give you a few seconds to chat. Okay, yes, Esther, but Ivan absolutely got it. All right, and let's see. Yes, Giselle also got it. All right, that's fine. Of course, I'm not going to tell you, or else we would end the conference right here. And I could kill some time until 4, right? Okay, let us proceed. All right, mitotic figures. This is the other data that you get from the H&E. Mitotic figures inconspicuous. Ki-67 is low, about 1%. Now, let's talk about this. Very important. There are 3 very important additional histologic details. The big picture, and all the fragments look essentially the same from what I've shown you. Predominantly collagen with the small cells, cleared cytoplasm. But there are 3 additional histologic features. And I'm really big about this. When our oncologic surgical pathology fellows rotate neuropathology on service with me, we always look at every fragment and every slide. For example, if it's a transcranial resection of a pituitary adenoma, we look for pars intermedia. We look for neurohypophysis. We look for RAPI cyst. We look for salivary gland rests, all of this stuff. We look, it's important, and I will put that in my comment, which is essentially the MD Anderson equivalent of a microscopic, because it could be important. All right, let me show you. Let's look at the 3 details. Rather than calling them details or minutia or incidental, I would like for you to think about it as essentially 3 additional clues to the diagnosis. All right, first up, what do you see? Anyone want to make a call here? And I'll give you a second to say what new feature has shown up. Some new feature has shown up in the histology. Anyone recognize it? It's important. It's a totally different cellular constituent. Anyone got it? Yes, Esther Ivan got it. Yes, Patricia Pittman, very good job. Absolutely. All right, here's a hint for those of you who haven't picked it up. All right, what is that? I'll give you another second to look at it, study it. All right, that's enough. Let's go to immuno for 2 additional hints. I'm giving you two additional immunostains. Here's the SOX10, the area that I just highlighted with the box. Look at how you have this prominent nuclear staining only in that area, not in the rest of the tumor. This is SOX10. Okay, again, we could create a differential diagnosis. We could create a Venn diagram sphere, a separate sphere of immunophenotype. Absolutely. And you would be listening or thinking about all the cellular constituents, both normal and neoplastic, reactive, that show strong nuclear SOX10 expression. Well, let me give you one more hint. This is a little bit easier. There's the S100 protein. At this point, you probably figured out if you didn't know before, this is peripheral nerve. Yeah, unequivocally. So let's put them all together. We recognize it as pathologists, particularly as surgical pathologists. We can recognize tiny fragments of cauterized peripheral nerve. It's easy to recognize if you have an eye for it, and it's very important. And then when I give you the SOX10 and the S100, that's just confirming it. The Schwann cell nuclei, 4+ positive for the SOX10, and of course S100, the same thing. All right, so this is peripheral nerve fascicle. There are actually 2 or 3 in the specimen distributed throughout the various fragments. Now, because we are in the posterior fossa, which was the site of the biopsy and partial debulking, these are cranial nerve fascicles. All right, second histologic feature, detail, clue to the diagnosis. What is the collagen doing? We've already noted that it's the predominant component. Collagen is usually not that interesting, amorphous. We have various terms to describe it: blocky, shredded carrot, all these different different whimsical terms. What is the collagen doing in this particular example? Look for details. I'll give you just a few seconds to pick it up for the pathologists that are in a conference. Just one word. You know, what is it doing? All right, maybe it's coalescing. I like that rush off the top. But before coalescing, there's something else I'm looking for. What is the pattern? All right, this absolutely is hyalinized collagenous material. What is the pattern? Whirl. Yeah, sorry, I just missed that. Yes, it's whirl. It's whirling. Everyone see the whirls? Each one of these little collagen balls that are coalescing, as Dr. Alphatal pointed out, it's a whirl. They're little whirls. Now that's interesting. What do you think about whirling collagen? Does that ring a bell? Have you ever seen it, particularly in the context of oncologic neuropathology? Well, maybe not. I actually hope not, because if you haven't, then this is going to be a good day for you, because you're going to learn something really interesting and potentially useful. All right, whirling. Yeah, all these whirls. Yeah, interesting. Okay, now here's the third. This is I saved the best till last. This is by far the most interesting detail of the H&E stains. What is happening in some of the collagen whirls? Okay, this would be worth, if we were in person in the old Thursday morning Integrated Diagnostic Medicine Case Conference, this is where I would be offering a double espresso to anyone, or $10, whatever Starbucks is charging these days, to anyone who can tell me, give it an exact name to what is happening in the collagen whirls at 30,000 feet, low power view here. Okay, that's pretty tough, and that's okay, because it would be risky. All right, I'll point out the area. So here's the first hint. I'm going to show you where to look. All right, the one dead center, upper dead center, that is particularly critical. All right, particularly okay. Here we go. High power. What is happening in some of the whirls? What are those structures? Okay, we just got one thought of calcification. All right, how about the Somoma bodies? Yeah, calcification. You know, it's bothering me a little bit. It should be a little more bluish, a little more blue-purple for calcium salts. These look really intensely, listen, intensely eosinophilic, and they have a little bit of, of the shape. I'm sorry. For anyone in the audience, maybe a radiologist who still doesn't know where we're looking, this is it, it's the blue box. Sorry, that was sarcasm. I'll do the same thing to the pathologist when we're looking at the imaging, okay? Yeah, this is what we're talking about. There's actually a structure to these, and in its best florid manifestation, it's a beautiful structure. All right, so again, let me just show you, we'll back off just a little bit. Once you see them, once the eye catches it, all of a sudden, they're everywhere, all right? This is what Dr. Ginsberg, Larry Ginsberg, head and neck neuroradiologist par excellence, calls Moya Moya disease. Now, some of you may be thinking, oh, that's Moya Moya, Japanese puff of smoke. It's the vascular neovascularization, carotid artery stenosis, all that stuff. No. Dr. Ginsberg Moya Moya disease is the Moya look, the Moya see. All right, you only would understand that if you're from New York, if you hung out in New York. The Moya look, the Moya see. Yeah, now all of a sudden these are everywhere. Aren't you interested to know what they are? Again, let's go back to higher power. Now look at the structure to it. Can you see? They're not simply amorphous. Yes, Esther Bit Ivan just nailed it, but I'm going to hold off on that. Yes, good job. They have this beautiful structure. All right. Actually, can I give you a little hint? They're actually named after flowers. Isn't that interesting? All right, and here's just a few more. All right, I'm doing the thing that pathologists do. You know what we do? We all do it. It's endemic. We take too many pictures. We show too many pictures. It's irresistible. I'm sorry. I apologize. There's going to be more. All right, here it is. I know it's meaningless magnification, but now at least you can appreciate there is internal structure. All right. Yes, and just got it right there. Who was that? Someone just texted the exact answer. I like it. All right, this is perfect. This is the answer, and it is a huge key. It is a huge key. It is the key in the case. All right. Could you buy this as looking something like a flower with small petals? I hope you can. These are tyrosine-rich petaloid, like petals on a flower, tyrosine-rich petaloid crystals. All right, great. What about the clear cells? All right, let's turn our attention to the clear cells because collagen is collagen. It's found in so many different reactive and neoplastic processes. We need to know the identity of the cells. All right, again, they're clear cells, where there's a lot of different clear cells. All right, what about S100? All right, this is the same slide that I'd shown you when we're looking at that peripheral nerve lighting up. Look at to the far right, and what you're seeing in the far right, basically the tumor cells, there's a little bit of staining, a small subset may stain, but the majority of the cells are negative for S100 protein. That does not really fit well for any form of trigeminal schwannoma. Schwannomas should be 4+ positive. Look at Ki67, about 1%. This is not a malignant peripheral nerve sheath tumor. I know it looked big and ugly, but you know, did it really spring that way overnight? 2-week history of headaches due to obstructive hydrocephalus? Probably not. All right, so essentially the tumor cells are largely negative for S100 protein. All right, let's look at some other. How about EMA? And this is the low power. This is the WSI whole slide imaging. This is the whole thing digitized. Looks negative. Looks like only hematoxin, doesn't it? But a little bit of blushy stuff. Why don't we look at these areas, these patchy areas? And there it is. Turns out it is beautifully positive, focally, multifocal, both membranous. Can you appreciate the little outlines of some of the cells? Membranous and cytoplasmic pattern. Oh, that is as good as it gets. All right, with respect to this particular entity. In fact, if it's much stronger, if it's 4+ diffuse strong everywhere, you're probably not using the marker for the tumor we're talking about. That's actually a warning. Guess what? Progesterone receptor, nuclear marker, also diffusely positive. And SSTR2, who knows what that is? I have a show of hands. It was Thursday morning, show of hands, just shout it out. You know, I'd be hearing all this stuff. I know this is way too long to type. You cannot type this. Do not even try, okay? Yeah, Giselle Lopez at Duke University. Yes, somatostatin receptor 2. Exactly, good job. That's exactly what it is. We're talking about meningioma markers. The old one, EMA, used to be, that's pretty much all we had. It was not a good marker. Frequently, it was weak, patchy, focal. Usually it was sort of like PLAP in germinoma. The best we had, described by Hannes Vogel and Stu Schnitt. Yes, the breast pathologist Stu Schnitt. So for all of the oncologic surgical pathology fellows listening, I just brought in breast pathology to the Neuro-Oncology Integrated Diagnostic Medicine Case Conference. Okay, anyway, here we go. And there it is. There it is. Let's go back to that. Sorry, at high power. You can see beautiful, diffuse, strong, robust marker for meningioma, SSTR2. Not pathognomonic, robust. So SSTR2, PR, EMA, all of these meningioma markers. Could this be a meningioma? All right, well, let's look at the facts. We're talking about Venn diagram sphere. What are the facts? 19-year-old patient. Essentially, that's pediatric/adolescent. Do children and adolescents develop meningiomas? Yes, absolutely. Do they constitute 30% of all primary brain tumors in children and adolescents? No, it's more like about maybe 1 to 4 or 5% max, but absolutely. And we see them all the time. And guess who sees even more? Across the street, Texas Children's Hospital. In fact, one of the most beautiful examples that I've seen over the last 5 years came from TCH. 19 years old, that's fine for meningioma. Female, well, yeah, meningiomas are most common in female, correct? Except in which age demographic? Answer, children. As a whole, listen, as a whole, pediatric meningiomas are slightly more common in males, in contrast to the adult situation. Slightly more common in males. This is a female. That's true for all of the meningioma subtypes, except the one that we're looking at right here, which is more common in women. All right, what about a 2-week history, headache, gait imbalance? Yeah, sure. That's fine for a big, slow-growing meningioma. That could develop obstructive hydrocephalus. Patient had it, absolutely. No neurological signs or symptoms or cranial nerve deficits. Again, that fits very poorly with trigeminal schwannoma. Sure, that's just obstructive hydrocephalus and this sort of thing. Yeah, that would be fine for meningioma. All right, rest of the data, H&E, clear cells, blocky collagen, petaloid crystals, Meckel's cave involvement, centered in the posterior fossa, specifically cerebellopontine angle, but with involvement going up, following the course of the trigeminal nerve. We have all of that. So here and there's all the data, everything together. This is everything we know. Now, guess what? Remember, we have talked many times about the 8-Venn diagram sphere model, data sphere model for precise oncologic diagnosis. We have 7 of the data spheres right here. We have 7 of them. We can complete 7 of those spheres, overlap 7 of those spheres. The only sphere we don't have is molecular signature. All right, so based on the data that we have, is there any type of meningioma that would be perfectly congruent with all of the data in these 7 Venn diagram data sphere models? Guess what? Trigeminal schwannoma is not, doesn't fit it. What about a type of meningioma? Okay, look, here's the 8 data spheres if you're not familiar with the model. Age, gender, clinical history, anatomic location, imaging characteristics, histologic features, which could include electron microscopy, cytologic features, histologic architecture, electron microscopy, that's all I call histology, differentiation markers we usually do by immunohistochemistry, and molecular signature. Those are the 8 spheres, and where they overlap in the octagon in the center will be the precise diagnosis. All right, that's how it works. All right, what can we do? Here's what we have. Start at the top. Age, 19 years. Gender, female. History, 2-week history, headache, and imbalance. Anatomic location, cerebellopontine ankle extending to Meckel's cave. Living in the cranial nerve 5 habitat, we could say. Imaging characteristics, multicystic, not dura-based. Ooh, do we like that for meningioma? Most meningiomas are dura-based, aren't they? I know it can occur. Sometimes they're not, but okay. Histology, collagen, whirling collagen, and clear cells and petalloid crystals forming in the whorls, right? You know, cellular whorls in transitional meningioma can develop Samoma bodies. That's where the Samoma bodies form, in the center of the cellular whorls. Guess what can form in the center of these acellular collagen whorls in this particular variant? Tyrosine-rich petalloid crystals. Isn't that a cool parallel? All right, and then for differentiation markers, EMA, PR, SSTR2, meningioma markers are positives. A whole bunch of immuno that was done, immunophenotypic profiling with negative markers that I'm not going to touch on in the interest of time. The only thing we don't have is molecular signature. All right, let's pursue this. Here's what I want to do. Let's start with the petalloid crystals, because I want to make sure that everyone that's tuned into this conference, this session today, I want to make sure that no one leaves this conference without knowing what petalloid crystals are. All right, I know it's one little data sphere, tiny little micro data sphere. Everyone needs to know it. These are tyrosine rich, and that's only because the initial detection technique detected tyrosine. Basically, it's proteins, amino acid rich, because that's based on the assay. All right, tyrosine rich petalloid crystals, initially described in salivary gland tumors. Here we go, Thomas and Hutt, this is J. Clin Path 1981, tyrosine crystals in salivary gland tumors. This is 24 of 113 salivary gland pleomorphic adenomas, yada, yada, yada. This is 1981. I know you're saying, well, I don't know about these tyrosine crystals because I fall a little bit behind in reading of the literature. So you're about 20 years behind in reading the literature. I know how it is. Well, it's not going to get any easier. You really need to start today, right? If you're that behind. Guess what? It's actually worse. It's actually worse. I kind of wanted to spare you, but I don't think I can do it. Let's just show you one of black and white, beautiful. Look at this radial rosette appearance of tyrosine crystals. See, again, the beautiful structure of the petalloid crystals. Here's the problem, though. This is not the locus classicus. What's a locus classicus? The locus classicus is literally the classic site. It's the original paper, usually, that described the finding. It's not 1981. 1953 was the initial description. AJCP, mixed tumor of parotid gland with tyrosine crystals in the matrix, 1953. So we've known about this for a while. Here's the actual front page of the article, mixed tumor of the parotid gland, tyrosine crystals in the matrix by Weldon Bullock. So Weldon Bullock immortalized initial description of these tyrosine-rich petalloid crystals. And there you can see again in black and white the crystals. All right. Okay, so the question for us, now you know the history of these tyrosine-rich petalloid crystals by sheer number of cases most commonly encountered in salivary gland tumors, multiple types, right? Head and neck pathology. All right, my good friend and colleague, Dr. Diana Bell, is all over these. All right, Are they seen? Can they be seen in meningioma? Well, if you don't know, what would you do? Well, the first thing that you would do, you would just simply do a Google Scholar or a PubMed search and, find out. Turns out, guess what? Ultrastructural pathology, 1999. Fibrous meningioma with tyrosine-rich crystals. This was the first example of a meningioma in which the tyrosine-rich crystals were seen. Now, look at the authors on this paper. Oh my goodness, Ari Perry, John Kepish, the original Dr. Meningioma, he wrote the book, and the late, great Bernd Scheitauer. These are three giants, if you will, giants of meningioma biology, meningioma neuropathology. Wow, that is huge. Again, black and white, but you can see these gorgeous high-power views of the crystals. And of course, this is Bernd Scheitauer. Dr. Scheitauer was big on ultrastructure electron microscopy. This is what they look like, all right? And let's look at his description. Floral, that means flower. Floral tyrosine-rich crystals with petal-like plates. Well, if you're going to call them floral, then you have to make them have petals, et cetera, et cetera. Absolutely, that's gorgeous. All right, look at that, writ small, and then here are ours writ medium large, if you will, not as large as a real flower, but you see where these grow, where they come from, hence the analogy. Do you like it? Oh, this is good. This is up close and personal. You're actually encountering the case, and you're having a Socratic experience, just like in the original movie Paper Chase. That's right. Okay, let's fast forward. IGSP 2018, meningioma with tyrosine-rich crystalloids, case report, review of the literature. This is 2018. Yes, they're still being seen. It's not simply one case. And now, how about full color? All right, you like that? Look at those. Those are gorgeous. The ones in our case look more like that, the upper left ones there that are a little bit fuzzier, a little bit smaller. I guarantee you that these were the best collection, and that is the single best tyrosine-rich petaloid crystalloid in this entire tumor. I guarantee you, and that's why the authors chose it. I don't blame them. Okay, fine. This was also fibrous meningioma. All right, so fine, fibrous meningioma. But wait a minute, we're thinking about clear cell meningioma. We're thinking about clear cell. Quick question, have tyrosine-rich petaloid crystalloids been reported in clear cell meningioma? Yeah, of course they have. All right, same journal, International Journal of Surgical Pathology, 2012, a case of clear cell meningioma with tyrosine-rich crystals. Yes, indeed. All right, let's have a look. Oh, lumbar cistern, the T2. And you can see it's sausage-shaped. I think it's a misdiagnosed myxopapillary ependymoma, or maybe a misdiagnosed paraganglioma of the phylum terminale, right? Do you see, I know it's not T1 with contrast, but do you see the angles that the tumor is making with the adjacent dura? I don't see a dural tail anywhere. In fact, there is no dural tail. And there is no dural tail because this is a clear cell meningioma of the lumbar cistern, and clear cell meningiomas of the lumbar cistern do not have any dural attachment. Did you know that? If you didn't know that, now you do. So here's the thing. Let's update our database. Let's do some new thing here. The next time that you see this image, and this is classic, listen, this is classic imaging of myxopapillary ependymoma and of paraganglioma of the phylum terminale. Next time, you better add clear cell meningioma, right? The full morphologic spectrum of clear cell meningiomas, which we'll talk about in just a second, to your differential diagnosis list. Turns out, I'm getting ahead of the story, the two most common anatomic locations for clear cell meningioma are, number one, the cerebellopontine angle, and number two, the lumbar cistern, where they originate from the arachnoid surrounding the leptomeninges, arachnoid surrounding the cauda. All right, and look, you're ready for the test. It's an open book exam. Two most characteristic anatomic locations, lumbar cistern, originating from leptomeninges. I just said all of that, no dural attachment. This is reinforcement. Everyone needs repetition. And the cerebellopontine angle, all right? Guess what? Look at our case, posterior fossa cerebellopontine angle. All right, let's go back to that case report. Look at the histology. Oh, wow. Does that look exactly like our case? Yes, maybe a little bit less collagen, but this is a maturation. It's an aging process. All right, and the collagen tends to become more prominent the longer the tumor is there, the older the patient, et cetera, and then they tend to coalesce, et cetera. Look at the whorls. They're all whorls, and in the center of Almost all of these are the tyrosine-rich petaloid crystals in the lumbar system. Now, here's the point. Listen up. What this means is once you have the look on H&E, the spectrum of clear cell meningioma, it's not just solid sheets of clear cells mimicking oligodendroglioma. That is one very common morphologic variant. No collagen at all, none. Just sheets of fried egg cells. Absolutely, clear cell meningioma with everything, no not yada, yada, yada. All right. However, this is another morphologic variant. And this is the variant that I want you to be able to recognize. Everyone knows the variant where it's just clear cells, but did you know about this variant called sclerosing? We'll get there in a second. Yes, I want you to burn this into your brain. Look at the EMA. You know what? That's not any better than the one of our case. What I'm saying about the point about EMA, it's frequently weak, focal, patchy, right? Don't just write it off, call it negative because it doesn't stain like a carcinoma. Come on. All right, and again, these authors also had access to electron microscopy, beautiful ultrastructure. All right, but look, okay, fine. So clear cell meningioma can have little collagen balls and petaloid crystals, but can clear cell meningioma look like this? I mean, this is way beyond the pale. Dr. Rosh Alfatal said earlier they were coalescing. Yeah, they're coalescing like crazy, and they're excluding all the meningioma cells, and it gets a lot more prominent than this. And what you have are these large acellular collagen whorls. I mean, this tumor, can become 95% collagen. Would you recognize it? Listen, would you recognize it if it looked like that? You're not even going to be thinking meningioma if you don't know this tumor. All you're seeing is a tumor that's 95, 98% collagen, right? In a few little small round to oval cells, maybe clear, maybe not clear, maybe eosinophilic cytoplasm. But if you know the entity and it's in the lumbar system or the cerebellopontine angle, or even it's not one of the rare sites of supratentorial, you're going to think, as long as you think about it and you're differential, because you have seen a case, you're going to get it. Okay, let's cut to the chase. What's the name of the tumor? It has a name. It's called sclerosing meningioma. What question? What is sclerosing meningioma? Answer. It is a morphologic variant of clear cell meningioma WHO grade 2, which develops a lot of collagen in the stroma. Stroma is one of the most variable parts of all tumors. It doesn't matter whether you're talking about carcinomas, sarcomas, metastases, whatever. The stroma is highly variable. Sclerosing meningioma, all right? And this was a study of 4 cases. Look at these axials and 2 axials and a coronal. Look where it is. It's in the cerebellopontine angle. And what's it doing? Look at the middle panel. What is it doing? From the key, tumor in the left Meckel's cave. Yes, they absolutely do that. All right, here's another one. Just again, neuropathology applied to neurobiology, 2004, sclerosing meningioma, immunohistochemistry, 5 cases. All right, now I know it's black and white. Look, you're going to have to deal with black and white. You say, no, I've got to have beautiful color. And even the neuroradiologist will say, no, I need it to be like the colorized DTI, no, black and white is fine. You know what? Sometimes you can get the best look at the cytology and architecture of a tissue section on a negative hematoxylin stained immunoslide. A negative hematoxylin stained, hematoxylin only, no eosin. Sometimes you see beautiful nuclear architecture. Sometimes mitotic figures are easy to see, et cetera, et cetera. So you can deal with black and white. Bottom line, look at the panel on the left. There's a high power showing you clear cells. But if you look at that panel on the left, that's all solid collagen. Look how many meningioma cells you see there. Maybe 6 to 10. Okay, let's go to the Great Barrett-Shai Tower. A review, active neuropathological 1990, tumors of the meninges, proposed modifications to the WHO classification, and look was in figure 1 and 1A, clear cell or glycogen-rich meningioma, and look at the panel he chose to illustrate the spectrum of morphology for clear cell meningioma on the right. Let's read it. A characteristic pattern of hyelinization may be seen in older, longer-standing tumors, all right? Isn't that super cool? This is actually a PAS showing the glycogen 4+, would have been drop dead gorgeous in color. Barrett-Shai Tower was very familiar with this way back then. All right, what's the locus classicus? Locus classicus, Davidson and Hope, Cancer, Journal Cancer, 1989. Meningeal tumors, meningiomas in childhood. Look at figure 1. Most of the sclerosing meningioma consists of almost acellular collagen. All right. Okay, fine. But what about whorls? Same paper. Yes, absolutely. Davison and Hope. And what you see, Davidson and Hope, in the collagenous and virtually acellular part of the lesion, the whirling pattern is evident. Yes, way back then, Davidson and Hope. Here's another figure from the paper. Collagen is laid down in concentric layers by whirling meningothelial cells. All right, NAN, fibrous meningeal tumors with extensive non-calcifying collagenous whorls and GFA protein expression. Okay, I want you to forget about the GFAP expression. That's really not been borne out, okay? But this was a fantastic paper, and this really brought attention. This is by there's several famous neuropathologists, oncologic neuropathologists here. If you look at the last one, senior author, Dr. Budka, fantastic, wonderful oncologic neuropathology, one of my mentors when I was coming up in the discipline, also is a wonderful human being. All right, but look at this, whirling sclerosing variant of meningioma. Question, what is the whirling sclerosing variant of meningioma? Answer, it is a morphologic variant of clear cell meningioma WHO grade 2. All right, in which the tumor, the stroma develops dense collagen in the form of whorls. The whorls grow over time and they coalesce. Yes, here are the figures from that paper, and you can see all the whorls, predominantly whorls of collagen and coalescing. All right, you're getting the full spectrum here. Meningioma with extensive non-calcifying collagenous whorls and GFAP protein. Okay, you know, this is just kind of jump on the bandwagon, try it yourself if you want. Listen, the reason why I wanted to show this paper though, look at the second author, top line, Claudio Tatsui. All right, everyone at MD Anderson Cancer Center, this is our Claudio Tatsui. So before he became a world famous spine neurosurgeon at MD Anderson Cancer Center, he dabbled in cytopathology. Of course, he was a neurosurgeon on this case. Isn't that fantastic? Look from the paper, look at the tumor, posterior fossa, look how large that tumor is. And then on the right, the left part of the panel, dense collagen balls whirling, and on the right, more of the clear cells. All right, let's go one more. Spine, whirling sclerosing variant of meningioma of the spine. And here it is. Again, look at that panel A, almost just solid collagen. All right, here's the point. Why am I doing all this? The point is to show you the spectrum of clear cell meningioma, and so that you are familiar with both the sclerosing and the whirling sclerosing clear cell meningioma. Test question. All right, pop quiz, honor system. You can all send your scores in to me afterwards. Are the whorls in whirling sclerosing meningioma the same as the whorls in traditional meningioma? Look, everybody knows, you know, third graders know that meningiomas have whorls, right? A whorl is a whorl is a whorl, right? No, the whorls, again, this is to reemphasize the point. The whorls in whirling sclerosing meningioma are acellular collagen whorls, collagen whorls. The whorls in transitional meningioma are cellular meningothelial whorls. Acellular collagen whorls of whirling sclerosing variant of clear cell meningioma can develop tyrosine-rich petalloid crystals. Cellular meningothelial whorls can develop Samoma bodies in their center. Okay, fine. All right, let me get this straight. I want to make sure I've got it straight. All right, so just text me, whatever, email me after if I've got it wrong. The overarching entity that we are discussing in this conference is clear cell meningioma WHO grade 2. Yes, that is a take-home message. Clear cell meningioma exhibits a morphologic spectrum. I thought that clear cell meningioma, all the pictures I've seen in the textbooks, all the pictures I've seen in the conferences were just sheets of clear cells, fried egg artifact. Looks like an oligodendroglioma. Does clear cell exhibit? Yes, there is a spectrum, and it's hierarchical. It's hierarchical. Look, it goes like this. Clear cell meningioma, you want to call it classic type, compact sheets of clear cells. Absolutely, extremely common, probably the most common variant. Subtype, clear cell meningioma sclerosing, develops collagen balls, whorls. Subset of sclerosing, these little collagen balls get really big and the whirling is maintained, and that's called, and they predominate, they outnumber, they out volume the compartment occupied by the meningioma cells, and that can be referred to as whirling sclerosing subtype. But all of these or clear cell meningioma. We can add an asterisk to the sclerosing and whirling sclerosing, not to the traditional type so much. May form tyrosine-rich petalloid crystals. That's another flavor variant. Now you know about that. All right, here's another factoids. All right, interesting factoids, which could become very important when you're dealing with a patient, a human, in your hands. Clear cell meningiomas are definitely most common in young patients in the pediatric age group and adolescent age group, as in the present case. The two most common anatomic locations, I'm saying not exclusive, but most common, cerebellopontine angle and lumbar cistern. Often no dural attachment. All right, can a non-dura-based intradural extramedullary tumor be a meningioma? Yes, absolutely. All right, let's relook at CPA meningioma. Hey, wait a minute. Cerebellopontine angle is a very common location for meningiomas. The majority are dura-based, beautiful dural tail. I presented them before at this conference. So let's have a differential diagnosis. Why don't we have a two Venn diagram sphere model for CPA meningioma, dura-based and non-dura-based. If it's non-dura-based, you don't detect it, then clear cell goes up on your list. And why is that important? WHO grade 2 tend to recur with higher frequency. All right, you like that? Okay, I got it. I got that. But that's always something with me. Come on, look at that Meckel's cave. I'm not sure. I mean, look at this. Have you ever seen it? Seriously, I'm asking everyone, have you ever seen it? Let me ask you a follow-up question. I thought that if I haven't seen it, then no one has seen it. What do you think about that? You will hear that. If I haven't seen it, no one's seen it. If I haven't seen it, it can't be that. Come on. I mean, I love the confidence and the hubris. There are things, I guarantee you, honest to goodness, Peter Berger, he's retired now, but he's still doing the things he loves. There are things Peter Berger has not seen, and he would admit that. Very few, very few, I imagine. And I don't think there's anything that Dr. Scheitauer hadn't seen. Anyway, that does not apply to you. Okay, no dural attachment. Yes. It parallels the course of the fifth nerve. Come on, I want this to be a trigeminal schwannoma. I really want it to be. I don't want to hear about the patient's symptom. I don't want to hear about the histology. I want to look at the imaging, and I want to make this a big trigeminal schwannoma, and I'm going to report it as a giant trigeminal schwannoma. What about the patient's signs and symptoms? I don't care. Well, what do you think I am, physician? I'm a radiologist, I'm a neuroradiologist. What do you think I'm a physician? I'm a pathologist. I look at H&Es. You want me to pay attention to 8 Venn diagram spheres? You know I'm being sarcastic. This is a fun conference. We have fun. I'm talking to myself, not just to you. You understand that. I am talking to myself because I want to do this too every day. I get a complicated, slightly difficult, a little funny thing, one funny thing in a tumor. I want to ignore it. I want to ignore it. All right, and just go the easy route, make the diagnosis. Who's going to know? Especially maybe if it's this lower grade tumor. Well, you know what? We're talking about ethics here. We're talking about character, doing your due diligence, being a physician. Okay, fine. All right. Okay, fine. The patient's signs and symptoms don't fit with trigeminal schwannoma. Fine, but can clear cell meningioma of the cerebellopontine angle really do this? I mean, mimic trigeminal schwannoma this good on imaging this good? Well, I don't know. What does this paper say? Clear cell meningioma masquerading as trigeminal schwannoma. Oh, let's look at it. It's in Meckel's cave. Contrast enhancing axial section shows large lobulated dumbbell shaped extraaxial mesh left CPA extension in the middle cranial fossa. All right, look at that. Look at the white arrow. Meckel's cave. Absolutely. Legend, post-gadolinium axial sagittal image showing heterogeneous enhancement of the tumor with the tongue of tumor white area extending in the region of Meckel's cave. Absolutely. This is our case. The two little images I added to the right, that you see their case, you see our case. Absolutely. It's there. It's there in the literature. Don't get lazy. Do your due diligence. Use the 8 Venn diagram spheres. They will save your life. More importantly, maybe your life is not so important in this context. The patient's life. That the patient is treated properly with the right diagnosis, that's what is important. All right, look at this paper, Canadian Journal of Neurological Sciences, 2009. Extradural middle fossa approach. Okay, this is a surgical paper. It's about the surgical approach. You see Cynthia Hawkins there on the paper. Look at this. Legend. Imaging features mimicking trigeminal schwannoma. I like these two writ large. I mean, look at that. Just take a second to soak in how big this tumor is from CPA. It basically just puts straight into medulla. Let's just make it one big cavity. How about that? That's what this meningioma is showing. Impressive? Let it sink in. Okay. The question I posed, is there a meningioma subtype that fits with all of this data? The answer, yes. Clear cell meningioma sclerosing subtype fits perfectly with all 7 Venn diagram data spheres that we have. All right, we're missing one, molecular signature. All right, here's recurrent molecular alteration in clear cell meningioma. Is there something we can put in that 8th sphere? Sometimes there isn't. Sometimes there's not. There's no defining molecular signature, or it's vague, or maybe it can be 20 different alterations, from the pathway. There's one pathway, but there's 10 different steps, that are involved, 10 different enzymes, 10 different mediators, et cetera, et cetera. Is there, listen, is there a single recurrent molecular alteration, or a single molecule, I should say, a single gene, all right, involved in clear cell meningioma? Yes, absolutely. This was the initial paper. Nature Genetics, March 2013. A lot of times it starts with germline. The germline cases, the heritable cases, call our attention to it. And we have all this material here, and we figure it out. And then it turns out, guess what? The same alteration that we initially identified in germline also applies to sporadic cases. And that's the situation here. Loss of function mutations in SMARCE1 cause an inherited disorder of multiple meningiomas. Guess what? They're clear cell. No, journal pathology, germline SMARCE mutation predisposed to both spinal and cranial clear cell meningiomas. Pediatric intracranial clear cell meningioma associated with germline mutation SMARCE1. SMARCE1 mutations in pediatric clear cell meningioma. Okay, yeah, I think you've got it. Just reinforcing it. Now, I love this. This is the best part. The last paper I'm showing. Why? Because it's an immunohistochemical surrogate marker. Loss of, now look, is that italicized? SMARCE1? No, it's not italicized. It's all caps. It is human, and it is a protein. Loss of SMARCE1 protein expression is a specific diagnostic marker of clear cell meningioma, and they did the immuno, and they also did thorough molecular testing, a whole bunch of different mutations resulting in loss. It's not a single point mutation, doesn't matter. And here's the imaging. Look, look at the top panel first. Top panel, ABC. All right, this was, as you see in the legend, it's a microcystic meningioma. B and C are simply low and high power of SMARCE1 protein immunohistochemistry. You can see nuclear staining retained SMARCE1 normal. Look at E and F for the clear cell meningioma, and you can see retained nuclear staining in the endothelial cells and other normal cell types. Stone cold negative, loss of SMARCE1. So we have a surrogate. The only problem is that there are relatively few other tumors now in which this is the key or critical signature for targeted therapy for whatever. So it's a bit of an orphan antibody, and most institutions will not have it. You'll have to collaborate, outsource, et cetera. Same thing for molecular testing. SMARCE1 is not found on most next generation panels yet. I think that will change, especially as routine molecular testing of all meningiomas comes online on board, and it is coming. Then I think all of the genes which are relevant, since each of them usually only account for about maybe 5%, max 10%, somewhere like that of meningiomas, I think we'll be testing for all of them. Okay, so here it is. Let's complete this diagram for purpose of inclusion. Clear cell meningioma, sclerosing subtype, and let's add in the SMARCE1 inactivation, all right? I should have italicized that. My bad. Okay. And we could add clear cell meningioma, whirling, sclerosing subtype if we want to focus on the petaloid crystals, that sort of thing. Okay, this is the last little bit. We have just a few minutes left. Here's what I want to do. I want to show you the report of this patient. How do you handle all this in a pathology report? You know, the easy way is clear cell meningioma for grade 2. Bye. It's Friday. It's Friday afternoon. I am not staying late on Friday afternoon to write an intelligent, detailed, accurate path report, or maybe I am. Let's putting all of the pieces of the puzzle together. Surgical pathologists and diagnostic radiologists don't actually do anything. You know, I've said this a million times. All right, we don't do anything. We're not interventional radiologists that can embolize vascular malformations. I mean, I know there's some that have a foot in both worlds. Fine. Surgical pathologists do not do surgery. They don't give radiation therapy. They don't give chemotherapy. We don't do anything, but we know stuff that is critical to our patients. We know critical stuff. All right, let's look at the report. Here's how I handled this case. It's an outside case, a number of slides from which special studies were performed. PR, IHC at MD Anderson, SSTR at IHC at Mayo Medical Labs. We outsourced it. Brain, posterior fossa, craniotomy biopsy, debulking. Clear cell meningioma sclerosing subtype. I thought it was important to put that in there. W showed grade 2. That is what I bottom line in the diagnosis section. Right there it is. Okay, now we can go to the comment. H&E stained sections, initial surgical specimen showed characteristic morphologic features of sclerosing variant of clear cell meningioma. There's the refs, including a prominent background of fibrous stroma with a proclivity to form acellular collagen whorls, which in the most florid form, the acellular whorls can form the bulk of the tumor, resulting in a variant of sclerosing clear cell meningioma termed whorling sclerosing meningioma. Okay, that's just a little educational feature of the report. The interspersed meningioma cells show variably cleared or glycogen-rich cytoplasm. You can test that with PAS with or without diastase. An additional histologic feature previously reported in meningioma, including the clear cell subtype, which I showed you, is the conspicuous presence of intensely eosinophilic, tyrosine-rich petaloid or floral crystals, which form in the centers of the acellular collagen whorls. Several small cranial neurovascular segments are identified amid the meningioma tissue fragments on H&E stained sections, and these are highlighted by S100 protein and SOX10 immunostaining. I think that's an important detail to have there, and it sort of explains a little bit why this meningioma is following the course of the trigeminal nerve. Maybe it originated from the intimate leptomeninges surrounding the nerve and is tracking along its course. We got some of the fascicles along with the resection, debulking. Mitotic figures are not readily identified H&E stained sections, KS67, labeling indices corresponding estimated frequency is low 1%. Low cell proliferation indices are a characteristic feature of clear cell meningioma. That is true. New paragraph. Differentiating marker immunophenotyping study performed by the reporting institution and MD Anderson and Mayo Medical Lab show tumor cell expression of several meningioma-associated markers, including EMA, which is multifocal membranous and cytoplasmic pattern, PR, multifocal nuclear pattern, and somatostatin receptor 2, SST2, strong, diffuse membranous and cytoplasmic pattern. All right, next paragraph. The diagnosis of clear cell meningioma sclerosing subtype grade 2 is congruent with the pre-op MR imaging studies. We always have a paragraph when we have imaging studies available that addresses the imaging studies in oncologic neuropathology of brain and spinal cord tumors, which show an extraaxial solid and cystic mass epicentered in the right posterior fossa cerebellopontine angle region with extension into the right cavernous sinus and right Meckel's cave. The distribution of the tumor thus parallels the course of the trigeminal nerve. Larger examples of clear cell meningioma in the posterior fossa are known to mimic trigeminal schwannoma, including extension into Meckel's cave. I've just given three examples there in the refs. One hypothesis concerning this close association is that the tumor may in some cases originate from the arachnoid surrounding the trigeminal nerve near the entrance of Meckel's cave. All right, the most commonly involved anatomic site for posterior fossa clear cell meningioma is the cerebellopontine angle. And similar to clear cell meningiomas arising in the other favored anatomic site, the leptomeninges surrounding cauda-equina lumbar cistern, they often lack a dural attachment, all right, as in the present case. Although dense adherence to surrounding structures is typical, as was also true of the present case. How do I know that? I read the op note. Dr. DeMonte, our expert, world-class, best in class, best in the world skull-based surgeon, I read his op notes. They are loaded with detail just like this pathology report. Clear cell meningioma most commonly occurs in younger patients of the pediatric adolescent age demographic, as in this case. Although in contrast to adult patients, pediatric meningioma is slightly more common in males, the clear cell subtype stands out in being more common in females, just like it in adults, only for this subtype. Isn't that a good fact to know? Yes. All right, and I think it's next paragraph. Always we address after imaging comes molecular signature. H&E, differentiation markers, imaging, molecular signature. The characteristic recurrent molecular alteration of clear cell meningioma for sporadic as well as germline context is biallelic inactivation of SMARCA1 with attendant loss of SMARCA1 protein expression. And finally, the constellation of clinical pathologic features, including patient age, patient gender, clinical history, anatomic location, imaging features, histologic features, cell proliferation indices, and differentiating marker immunophenotypic profile is characteristic of clear cell meningioma, sclerosing, morphologic subtype, WHO grade 2. Let's put a big red box around that. What does this say? What does this say to the neuro-oncologist? What does it say to the radiation oncologist? What it says is this pathologist has done their due diligence in using an 8-Venn diagram sphere model, which is the most stringent model for oncologic diagnosis. To fill those spheres, consider it, get the data, dig through the PDS, outside cases, etc. Do what you have to do to fill those spheres to get what plugs in there and get the precise diagnosis. It takes a ton of effort going through records. It takes a ton of effort on Google Scholar and PubMed and SN, you know, the SNP database, etc. All right, and look, there are the 18 references. Now, this is a lot, even for me. Even for me, this is a lot of references. I do not do this in every case. In fact, I don't think I've ever done it in any case. This was a first. That's why I thought it warranted presentation in this forum. But everything that we just discussed is documented. Again, this is an education function. If the patient leaves this institution, they're going to be going back home. They could move to out of state. They could move to Europe. They could go anywhere. This will go with them, and the data, the information for the radiation cause, what happened to these patients, the association, it's all there. All right. What is our product? Listen, for diagnostic radiologists, for surgical pathologists, what is our product? Our report is our product. That is what we do, and it is critical clinical care. It is critical. All right. Let me be honest in my final note. I'll be honest with you. I was 99% sure that I knew this was the first one. Look at the first H&E. Look at this H&E. Burn it in your brain. You know what it is now. A little bit higher power. And this was just icing on the cake to have the petaloid crystals. Okay, honest to goodness, I see this, I'm thinking this is clear cell meningioma sclerosing subtype. Why? Why could I do it that quick, that fast? Because I've seen them. I've seen them. I've seen a bunch of them. All right. Now it's taken me almost 30 years to see a bunch of them, like in person, not reading books and conferences and stuff like that. But yes, I've seen at least a dozen, maybe more. Right. And each one was an intimate, personal encounter with a patient, not a case, a person, a patient, each one of them. Yes, I'll never forget it. All right. So pathologists, burn this image into your brain, the sclerosing variant of clear cell meningioma. Icing on the cake if you get the tyrosine-rich petaloid crystals. All right, that being the case, from the H&U, I had the suspicion. I went to great lengths to confirm every detail and every Venn data sphere that I had, which were 7, don't have molecular signature, every sphere except the molecular, in order to serve my patient to the best of my ability. Okay, that's all I have. So I hope for everyone to have a fantastic weekend. Decompress if you're not on service, on call. Thank you for joining in. I couldn't do this without you, without your support. It's much appreciated. It motivates me. All right, with that, I'm going to end the conference, and listen, very quick. I will not see you next week. I am on service back in the hot zone next week, and I learned the hard way a couple of weeks ago. I'm probably going to have frozen sections on next Friday. So no conference next Friday, but I think I have a way that I can make it up to you via the internet. So look for an invitation coming through your email. All right. Let's see, what do I have? Oh, sorry. There we go. Follow me on Twitter and YouTube. Have a good weekend.